So abdominal pain. The key to making any diagnosis, and ultimately that's what you need to do, right? You need to make a diagnosis. Any plan has to be predicated on knowing what you're treating. So you need to know anatomy. God only puts things in certain areas, okay? So if someone comes in with belly pain, the thing you need to do, they'll say, my belly hurts, you say, where? And you often say one finger. So people go, well, my tummy hurts, my belly hurts. Haven't put one finger on it. And then the other thing you need to do is you need to expose them, all right? So if they got a lot of clothing or body armor or something, probably not here. Not so much at Cox Hospital, but you need to look at their belly. You need to get an idea of what it looks like with your eyes and then where it hurts. You should have an idea of what's in those regions, right? Right upper quadrant, liver, left upper, what? Spleen, yeah. Right lower, appendix, and left lower is where the turds are at, okay? So that's the descending colon. So it varies. There are other weird conditions where things are flipped, but in general, that's, God only designs things a certain way. So just know the anatomy and have an idea in your mind, okay? You have a cheat sheet on you at all times if you can't remember, right? You are the cheat sheet. So you know what's in your own belly. You can think, okay, well, that what lives there. So oftentimes I'll say, well, the only thing this can be is this, because that's what lives in that region, okay? That's what I'll say. So and there's kind of layout of what it is, okay? All right, and this goes through a little bit. So in the regions, you can build a differential diagnosis based upon whatever problem they're presenting with. One thing to be aware of, because the diaphragm divides the abdominal and thoracic cavity, things in the thorax can present with abdominal pain. So if you have a lower pneumonia, the only presenting complaint might be abdominal pain. Okay, so think outside of where you're at and don't get necessarily hemmed in on whatever the issue is, but be aware of it. Heart attack can sometimes present with only intestinal or GI complaints. Okay, so listen to the story. In general, the patient will tell you what's wrong if you listen to them. Certain circumstances you can't. You just have to make a decision and move with it, and that's like many things I think you guys do. Sometimes you just make a call. But making a call is often better than not doing anything. In medicine, you have to make a decision. So make a decision and move on. And then reassess your decision, just like any other problem in life, okay? So we talked about looking at it, looking at the belly. A lot of people, that's what a lot of people are in South Missouri because of too much carbohydrates. They're distended. But if they're supposed to be scaphoid like you guys are, right? I'm not scaphoid because I'm in my 40s, almost 50, so I'm not scaphoid. Scaphoid's like that, Their chesticles are bigger than their belly, so it's a little flat. If you laid a ruler, it would have a little space underneath it. Most people are like that. So you look at it. So lay them down flat and look at it. What do you do if you can't lay them flat? Do the best you can. Get an idea. Sometimes what I do when I talk to patients, I say, your belly looks a little distended. Is that normal for you? Oh, yeah, doc, it's always this way. Cool, no problem. Now I have a reference point. But if I'm laying them down flat looking at them, I kind of get an idea. If I see an area that's more distended, or maybe they have a bruise, then I'm thinking, based upon the history of what happened. Someone gets kicked or falls off a horse, and they got a bruise on the left upper quadrant, and it's kind of poochy, I might think of what? Spleen injury, yeah, or some type of problem. So you kind of get a look at it. And then you can listen. So normal bowel sounds, maybe nothing. And honestly, how many times do I hear anything of significance? Not very often. The classic would be high-pitched tinkling. In there's certain cases that might be a bowel obstruction. So you just kind of build this case, and you kind of get a sense taking the whole thing together. And then you palpate them. Now they'll teach you to put your hand, one hand and kind of push with the other. But I'll be honest, what I do is I'm talking to the patient and I'm looking at them and I'm palpating them all at the same time. So you can get this done real quick. You don't have to divide it up, okay? The best is just to work out something, a sequence that works good for you. Hey, buddy, what's going on? Your belly hurts. Does it hurt here? Can you point at it? Does it hurt when I poke over here, or how about here? You get what I'm getting at? Does that make sense? Okay.